Our next speaker, I actually haven't even met him in person yet, but I see him here because he's just flown in from Halifax, Nova Scotia. Dr. Michael Ripley, he's a reproductive endocrinologist at Atlantic Assisted Reproductive Therapies, as well as an assistant professor in obstetrics and gynecology at Dalhousie University. He completed a fellowship in gynecologic reproductive medicine at the University of Ottawa and Ottawa's Fertility Centre in 2015. He graduated medical school and completed residency in obstetrics and gynecology in Dalhousie, and his clinical interests include markers of ovarian reserve, fertility preservation, and recurrent pregnancy loss. And he's here to speak to us about chemotherapy and fertility in young patients. Please welcome Dr. Ripley.
Perfect. Thank you very much for the introduction. It's an honor to have the opportunity to talk to this group today. There we go. So this is essentially what I do. I work at the fertility clinic in Halifax, as you just heard. It's certainly not just me. We have a huge team of embryologists, of nurses, of pharmacy, admin staff. And there are 3 docs that work at the clinic, which I guess we weren't available for the group photo, I guess. But anyway, sometimes we take pictures with the whole crew. So this is what we're going to talk about today. So gastric cancer demographics, because I think they're actually quite pertinent to this topic. The effects of cancer therapies on fertility. Fertility preservation options for male and female patients, which those 2 things are quite different. And then other considerations like cost and procedural risks. So, I mean, this is not news to anybody in this room, but, you know, gastric cancer isn't something, honestly, that I see a lot of for fertility preservation for the reasons that are kind of listed on the slide here. So it's twice as common in men, but more importantly, the average age of diagnosis is, you know, beyond typical reproductive years. And, you know, a smaller portion of patients are diagnosed under the age of 40 in, you know, what I think most of us would be considered to be kind of like the reproductive lifespan. There also are, as you guys know, a number of sort of cancer syndromes, as well as in some cases specific genes that can predispose somebody to this disease. I'm going to talk about that just a little bit at the end. In terms of chemotherapy, I mean, risk to your gonads from chemotherapy is really related to 3 things. It's basically the age you are when you receive the treatment, what the specific drugs are that you get, and then the sort of dose and duration of those medications. And so, like, some chemotherapeutics are not gonadotoxic at all, like fluorouracil is not. But, you know, most gastric cancer chemos involve some type of platinum-based chemotherapy. I'm just going to talk about that in a second. Fertility preservation discussions, I mean, with increasing numbers of cancer survivors and hopefully improving outcomes, we're now focusing a lot on sort of quality of life after treatment. So that includes physical, psychological, and social, but I would argue reproductive health as well. And we know that we haven't always done a great job of this. So there's studies to suggest that 30 to 40% of male cancer patients said their physician or their oncologist did not discuss fertility preservation. They did a survey of oncologists at a large university, I believe it was Duke, where they said that 45% of these oncologists, like, self-reported, never referring for fertility preservation consultations. And they also have shown that 60% of American physicians were aware of the American Society of Clinical Oncology fertility preservation guidelines, but only 25% of them actually followed them on a regular basis. And so all this data is from about 10 years ago, and I would hope that things are kind of improving now. This discussion should occur really at 2 points, at the time of diagnosis, but then also at the end of the initial treatment. Patients should be made aware of any potential risk to their fertility prior to undergoing treatment. And if immediate initiation of treatment is needed, or if because the patient's too ill to undergo fertility preservation, they should be informed of that and not just not referred. And really, I keep saying fertility preservation, and it's a bit of a misnomer, right? Because when we talk about preserving things, like I always use this example of jam, which is horrible because I don't know a thing about preserving jam. But my understanding is that if you make jam and you put it in that jar, when you want to have the jam in the future, it should still be, if you did it right, it should still be there for you to eat. Same with like nature preserves. Like you make them so that the number of wildlife in them will increase. And unless you're doing it really wrong, that should happen. Fertility preservation is a bit of a misnomer because there is not a guarantee by somebody freezing their eggs or freezing their sperm or freezing embryos that they are, yes, 100% going to be able to have a child from that genetic material that's been frozen. And even in the best case scenario, so somebody under the age of 35, with any given sort of embryo transfer with an IVF cycle, the chance of pregnancy is less than 50%, which is why I have the sort of like flipping a coin thing there. So really we should think about this as infertility risk reduction. So doing a treatment, taking a strategy that is going to, make it less likely that you won't be able to conceive offspring when you wish to. To talk about male patients, which is certainly the simpler of the two to talk about, this is a cross-section of a seminiferous tubule. We know that sperm production is affected by chemotherapy because the Sertoli cells, which make sperm, are more affected from chemo than the Leydig cells, which make testosterone, which is a lot of the time when people have chemotherapy and they become infertile, they don't like lose the ability to grow a beard or anything like that. So it's not necessarily that their testosterone is affected so much as their ability to make sperm is. So if you wipe out all the Sertoli cells, or even prior to that, wipe out all the germ cells that become Sertoli cells, that patient will become what we call azoospermic, or not have sperm in the ejaculate. And so chemotherapeutics are typically broken down in terms of the risk for fertility as high risk, medium risk, or low risk. And you can see here that like the platinum-based chemos are typically kind of medium risk, which that usually means a 20 to 80% risk of infertility, but like that's a really, really wide range. So I actually find that these are the patients that are the hardest to sort of counsel, because like 20 is very different than 80, but they all just kind of fall into this range. And you can see here, I mean, this is other types of cancer, but sort of the rates of resuming spermatogenesis or becoming azoospermic varies wildly depending on what the actual treatment regimen is. I'm trying to make this as relevant for this audience as possible, but there is just not really any fertility preservation data out there as it relates to gastric cancer patients. Because Folfox is used for colorectal cancer, I think that's probably the closest analogy, but even the colorectal cancer fertility preservation data is really, really lacking. So this was a study of, they said 20 male patients who did a semen analysis prior to chemotherapy, immediately after chemotherapy, and then 1 to 3 years later. But you can see, so it's really just the left side of this diagram, but really you can see that like only 9 patients did it immediately after chemo and only 7 did 1 to 3 years later. But what they did show with Folfox was pretty reassuring. So the blue bar there is prior to chemo. This is sperm count, by the way. And you can see that it dropped significantly during chemo, immediately after chemo, but then most of the people in this study did resume spermatogenesis afterwards. And the average sperm count was actually higher after treatment than before, which is probably just a small sample size kind of fluky thing. This is motility, so what percentage of the sperm are moving. You can see again, the red bar drops down from the blue bar because immediately after chemo, sperm don't swim as well, but then 1 to 3 years later, you can see the green box improves again. A couple things to keep in mind about this. Again, we're talking about 7 patients at the 1 to 3 year mark. Are those representative? Why did the other 20 not come back and do this? As well, we don't know that sperm motility and sperm count they don't necessarily mean that you have fertility. They mean that you have sperm in the ejaculate and that it's moving. It doesn't mean for sure that those sperm are going to fertilize an egg. When guys want to try to do fertility preservation prior to chemo, this is a really, really complicated chart. I put a little purple box around what really 99.9% of people do, which is they obtain a sperm sample for banking. So they basically go in a small room, masturbate into a little container, and then hand it off to somebody in the clinic, and then we freeze it. So So fairly straightforward. Key points about this, I think most of those things I've already said. If sperm count recovers, there's some guidance to suggest the patient should wait 1 to 2 years before attempting to conceive. And then also what people should know is that use of banked or frozen sperm requires IVF ICSI, which in and of itself comes with certain sort of commitments from if they have a female partner, and often can come with significant cost as well. We also know that this is not quite as good as it sounds, because when patients are sick, they often have abnormal sperm parameters just from having an acute illness. So this was 700 men that went to freeze their sperm. 64% had abnormal sperm parameters, and 12% of them actually were unable to freeze a sample because they had so few sperm in the ejaculate. And then as well, we know that most people don't come back to use this sperm when they freeze it. So I always mention to people 15% is kind of a good rough estimate of the percentage of people that actually come back looking to use their frozen sperm for their own reproductive purposes. The female side of things is much more complicated. It's kind of a busy graph, but really what you really need to pay attention to is just the red line there, which is number of oocytes, or it's like a fancy word for eggs, number of eggs in the ovaries over time. And you can see that the red line starts to fall even before birth is reached on the x-axis. So all women have the majority of the eggs that they're ever going to have while they are a 20-week fetus inside of their mother. And from there, the number of eggs declines even prior to birth, but certainly after birth as well. And women don't make more eggs over time. So it's kind of like a non-renewable resource at this point. And this is a marker of egg reserve, because you can't actually directly measure egg reserve without cutting somebody's ovaries out. So this is anti-Müllerian hormone, which is like a marker that is made by egg follicles within the ovaries. It's a blood test, and you can see that over time, ovarian reserve declines. This is another way to test ovarian reserve, doing an ultrasound and looking at those little black dots and just counting them. It's just really, really simple. Something called antral follicle count. This was a study out of McGill looking at, in their fertility clinic, at antral follicle counts by age. And again, you can see that it goes down over time. So we know that chemotherapy can affect ovarian reserve, or egg supply is kind of the simple way to think about it. So not every woman has the same ovarian reserve at onset. We know that it declines over time. So chemotherapy, you can think of it as like a sudden hit to your egg supply. And once you get below a certain egg supply, that is called menopause, and you stop ovulating. So that's kind of the concern here. So there can be two types of infertility from chemotherapy, either acute ovarian failures. Some patients that have chemo just stop ovulating and never ovulate again. But if the hit was not that great, it still might knock somebody down to a point where they reach menopause at an earlier age, which in effect is kind of shortening their reproductive lifespan. It doesn't give them as long an opportunity to try to conceive. And this is what I was saying about IVF in general, is that it is most effective when somebody is younger. And this is not fertility preservation data. This is just everybody out there that does IVF. This is sort of the reality of it. So despite what you see on the tabloids, it is not that easy to conceive when you're 50 years old, right? And we know that with female infertility as well, female chemo as well, that they're sort of broken down into high, intermediate, and low-risk chemos. And again, platinum-based chemo and Folfox sort of fall into that intermediate range. And this is actually from the Livestrong website as well. And again, it's Folfox rate listed by them as intermediate as well. This was a study, again, trying to make this as relevant as possible. Women with colorectal cancer, they were actually just sent a little survey about their periods sort of during their treatment. And what they showed was that about 40% of them or so during chemotherapy became amenorrheic or did not have periods. And then when they looked after chemotherapy, most of them actually resumed having periods. So 16% didn't. And as you might expect, you were a little bit less likely to resume having periods if you were older when you got chemotherapy, because your sort of supply at that point is already lower in terms of eggs. So the chemotherapy is kind of a bigger hit for you proportionally in that case. In terms of fertility preservation for women, it is more complicated because you can't just masturbate in a room in the clinic, right? So, you can, but you're not going to freeze anything and you do that. So anyway, I digress. So didn't mean to say it quite like that. But so fertility preservation options are kind of, I stole this from a Mayo Clinic, image on the internet, to be completely honest. So basically eggs come out, and then eggs can either be frozen initially, or they can be fertilized with sperm, and that's called an embryo, and then embryos can be frozen. And this very briefly in terms of IVF, does anybody know somebody that has done IVF before? Raise your hand. Yeah, okay, so news for you. The people that are not raising their hand, you do as well, you just don't know that they have. So in Canada, as of right now, 2% of all babies born are born through IVF. It's just not everybody talks about it. So IVF, this is a really boring slide. So IVF essentially is taking two different types of drugs over about a 2-week span. So one type of drug makes the ovaries grow a bunch of eggs all at the same time instead of just the one that does in any other month. And then taking a different type of medication that prevents ovulation from happening, because if you're growing a bunch of eggs and then they leave the ovaries and just randomly go into the pelvis, that's not helpful for us. So that's essentially what IVF is. And during that almost 2-week span, patients are having serial ultrasound as well as blood work to sort of monitor egg follicle growth. So all those black dots in that picture of an ovary right there are the follicles. So then once those follicles get big, so those follicles have eggs in them, but you can't see them because they're so small. Once those follicles get big, patients take this one last medication, then they do an egg retrieval 36 hours later. And they do get medication with this. So an egg retrieval is basically a needle going through the back of the vagina into the ovary on each side, and the needle's hooked up to suction. So the follicles, again, are kind of like little fluid-filled areas, has an egg in it. The egg gets sucked out into a little test tube, and then we hand those off to the embryology team. So if somebody's freezing embryos, there's 2 different ways to fertilize an egg. We fertilize the egg and make embryos, which we grow in the lab for 5 days. So a day 5 embryo is called a blastocyst. That's the thing on the right there. And we're able to freeze those. And this is something that's been going on for a very long time. Basically, any IVF clinic can also freeze embryos, and embryos can stay frozen indefinitely. It's not like, when you go to Costco and you get like that big pack of chicken, you put it in the back of your freezer, and then like 3 months later, it's got that like freezer fur on it. Yeah, that doesn't happen with embryos. So limitations with embryo freezing are that you either need a partner, like a male partner, or use donor sperm. And part of the problem with it is that if you have an embryo frozen, you're only legally allowed to do with it what the female, so like the person whose egg made up that embryo, as well as the person whose sperm made up that embryo, allow you to do. So you can imagine we have had in the past couples separate who have embryos frozen at the clinic, and then that embryo is kind of like in legal limbo at that point. So it's not ideal. So the other option is freezing eggs, which I just very slickly photoshopped that previous diagram there. I bet you can't tell that I did that at all. So basically eggs come out and then you freeze them. And they can be days, weeks, months, or years later thawed and then fertilized, and you make embryos that way. And so this has been going on since 1986, but it's become non-experimental since 2012. It is a little more challenging to freeze eggs from an embryology standpoint, but I think these days, like in the last 5 to 7 years, most clinics that do this kind of thing are quite good at it, I think including ours. And then egg freezing outcomes, the chance of pregnancy is about 4 to 6% per egg that's frozen. So like your prognosis is really based on the age you are when you freeze the eggs and how many eggs you freeze. So you want to try to maximize sort of that yield. Now doing IVF, as you might imagine, has some risks. So there's procedural risks of actually doing an egg retrieval. Patients, if we make too many eggs grow at the same time, like I'm talking 30 or 40, patients can get something called ovarian hyperstimulation syndrome, which obviously in an oncology patient we want to avoid because we don't want to delay their chemo start date by any more than we absolutely have to. And then cost is a factor as well. In cancer patients, there's 2 other additional considerations. Risk of delaying the treatment. I know personally, I'm not going to start somebody into an IVF cycle unless I personally speak with their oncologist to make sure I'm getting the full story and the oncologist is comfortable with this. And then risk of the ovarian stimulation on their cancer outcome. This is probably not quite as relevant to gastric cancer, but like breast cancer, for example, if somebody has a estrogen receptor positive tumor, does doing IVF affect their ultimate outcome? And there isn't really evidence that that's the case, but it's certainly something to talk about. So doing fertility treatments in Canada in most provinces is very expensive. There is a group that helps oncology patients pay for this type of thing. So the program is called Power of Hope. The organization is called Fertile Future. They have a bunch of sort of qualification criteria. And basically what happens is female patients will receive a cost reimbursement of about $1,000. Male patients, because sperm freezing doesn't even cost $1,000, can basically do it for free if they qualify for this program. And then partner clinics like ours agree to reduce their fees by a third. And then I usually can get drugs for free by compassionate care programs from a manufacturer, and there's one in particular that is really, really good at giving us drugs for oncology patients. So I put their name there. I don't have any kind of like relationship financially or anything with them, but just I appreciate it. At our clinic, this is still what this stuff costs, right? So to freeze eggs, even with everything that I just told you about the financial assistance available, can still be $4,000. Now, Ontario is a little different because there is funding in Ontario for fertility treatments, including oncofertility, for up to 1 cycle per person for their lifetime as it stands right now. But that is the exception. So most provinces in Canada, there is not a program that is nearly as generous as that. I was going to talk a little bit about pregnancy after cancer. There's not really a consensus on the best time to conceive after a patient has done their treatment. Patients are usually asked to wait kind of 2 years or so because this is kind of the time of the highest risk of recurrence. But ultimately, like, this decision should be made between the patient and their oncologist. Every fertility preservation program should have all of these things. So the main thing is rapid access, because these diagnoses are often unexpected, and sometimes patients' treatments start very, very soon. So, like, you know, if somebody gets referred to us, we can usually see them within 2 or 3 days. You need a multidisciplinary team within the clinic, an experienced lab within the clinic to do all of this sort of cryopreservation stuff that I was talking about. And then also even counselors, including mental health, like we have reproductive psychologists that work alongside of us, genetic counselors when we're talking about hereditary cancers, and occasionally financial as well because of the cost of all this stuff. And we need interdisciplinary collaboration, so certainly preferably a close relationship between the oncology team and the infertility team. Just very, very quickly, one other thing that I was going to mention is preimplantation genetic testing. So what this means is when you make that embryo on day 5 that I showed you, that little purple slide with the 5 different days of embryo growth, on day 5, an embryo can actually be biopsied. So you take a little sample of a few cells off of the embryo. The embryo is then frozen, and those cells that you take off can be sent to a genetics company or a genetics lab, and they can analyze them. And so this is something that is routinely done these days and is often done for single gene autosomal dominant disorders. So CDH1 in gastric cancer would be an example of this. I would say more commonly I see it for like Huntington's disease, where a patient, rather than like the patient themselves that carries that gene may not have infertility, but if they want to try to avoid passing that gene on to their offspring, which there'd be a 50-50 chance of that, they can do IVF, biopsy their embryo, and then basically sort of weed out embryos or sort of rule in embryos that don't carry that gene and then transfer that embryo into their uterus. So that's kind of this little slide here is clinical diagnosis needs to be a single gene disorder that we know where it exists, like basically what chromosome it's on, how do you map out and find the gene. And then basically the company will make a probe to detect that specific gene in that patient. So then the patient undergoes IVF. Very bottom there, they have a biopsy, and then from there, the sample, like the biopsy sample, is amplified so that there's like more of it, and then identified. And then so basically, the patient would get a report saying, okay, you biopsied these 8 embryos, 3 of them carry this gene, these 5 don't. You're going to transfer one of those embryos. So it's kind of seen as a way of sort of reducing the burden of disease sort of for your offspring or within that family. So that's certainly something that is commonly done these days. I've just thrown it out there. It's not specifically a fertility sort of preservation topic. So in conclusion, patients beginning cancer treatments should be informed of potential fertility risks. They need to be referred quickly and have a consultation with somebody like me if they desire these treatments, or at least even want to hear about them. Patients should be informed which options are standard practice and which are unproven or experimental. So for example, ovarian tissue cryopreservation, so basically like chopping off either a whole ovary or a piece of somebody's ovary and freezing it, is being done, but it's not really standard of care. And so, if a patient has one shot at doing this, they probably don't want to necessarily do the thing that's considered experimental. So that all needs to be very forthcoming. Fertility preservation, I think importantly, does not guarantee future fertility, but it does increase the likelihood of being able to have genetically related offspring in the future. And then discussion of options, I would say, is often welcomed by these patients, even if they have minimal desire to undergo fertility preservation or if they're a poor candidate for it. I remember when I started in practice a couple years ago, I had a patient that came to me for sort of hormone therapy because she was 20 and she had had chemo when she was 13 or so. And this was in 2017, I want to say. And she was still at that point pretty mad that nobody had talked to her about fertility preservation. And I remember thinking okay, so you would have been 13 at the time. We didn't even do egg freezing here in Halifax at the time. So there wasn't really going to be a good option. I sort of explained that to her and she still just kind of looked at me and said, I know, but I wish somebody would have actually sat down and told me that, because even that would have been helpful. So I think, if patients, even if they don't have a lot of interest in this, I think referral is still, for some of them, a valuable thing. So that is it. So thank you very much for your attention.